today's webinar, When OCD and Eating Disorders Overlap, Understanding the Connection. ADAA is very pleased to present this webinar in collaboration with the National Eating Disorders Association. My name is Jolie Busby, and I'm the Education and Training Manager at ADAA. And so with that, I'm very pleased to introduce our moderator for today, Molly Schlapp-Gilgoff. Molly is the Manager of Mission Initiatives at the National Eating Disorders Association. In her role, Molly oversees the development and updates of content and educational resources, supports the organization's awareness campaign, and fosters volunteer engagement. She is also dedicated to creating innovative strategies that connect individuals with essential information and resources. Welcome, Molly. Thank you for moderating today. I'm going to turn the presentation over to you now.
Thanks so much, Jolie. And I just want to echo what Jolie said and welcome everybody to the presentation. Again, I'm Molly Schlapp-Gilgoff. I'm one of the managers of Mission Initiatives at the National Eating Disorders Association. And we are so excited to be collaborating with the Anxiety and Depression Association of America. And before we get started, I just want to share a little bit about NEDA and the work that we do and some resources that might be helpful for you. NEDA is a nonprofit organization working to fundamentally change the way that eating disorders are understood and treated, and to empower those affected to achieve lasting well-being and recovery. Through campaigns like Eating Disorders Awareness Week and National Eating Disorders Screening Week, we're working to increase public understanding of these complex disorders. Our Grace Holland Cozine Resource Center connects individuals and loved ones with critical knowledge and lived experiences to find the help and support they need to navigate all stages of recovery. We educate communities through our Understanding Eating Disorders presentations, which we've hosted in corporate settings, schools, and other nonprofit organizations to help recognize early signs and have compassionate conversations. And we also invest in groundbreaking research that helps to develop effective treatments. And additionally, we promote early intervention through our screening tool, which has helped over 1 million people. I'd also like to just highlight 2 resources that are incredibly helpful. The first is our online screening tool, which is anonymous and appropriate for ages 13 and up. It helps determine if a person is at risk for an eating disorder and connects them with resources to encourage help seeking. This tool is also now available in both English and Spanish. The second is our updated toolkits. The first is the parent toolkit, which covers everything from how to have a supportive conversation to communicating with schools and treatment teams, the evaluation and treatment process, and much more. Our coach and athletic trainer toolkit helps staff working in sport environments learn how to create safe and supportive athletic settings and recognize signs, respond appropriately, and support athletes during and after treatment. And these can all be found on our website. So now I'd like to introduce our esteemed presenter, Dr. Norman H. Kim. Dr. Kim is a member of NEDA's Clinical Advisory Council and the inaugural Diversity, Equity, and Inclusion Officer for the Center for Practice Innovations at Columbia University Department of Psychiatry and the New York State Psychiatric Institute. He is also adjunct faculty in the New York University Department of Applied Psychology and the co-founder of the Institute of Anti-Racism and Equity, a social justice focused consultancy. Thank you so much, Dr. Kim, for being here and doing this presentation, and I'll hand it over to you.
All right, thank you, Molly and Jolie. Thank you both so much, and the organizations as well. Hopefully everyone can hear me and see the slides. Okay, so yeah, my name is Norman Kim. I'm I'm currently at the Columbia University Department of Psychiatry and the Center for Practice Innovations, and more relevant for this presentation today, I've had the privilege of working with and on behalf of people struggling with eating disorders and their families for over 20 years, and it's truly an honor to be speaking with you today. Today, we're going to be diving into a topic that's often misunderstood and overlooked, which is the significant overlap between obsessive compulsive disorder and eating disorders. This connection is a profound one and has critical implications for both diagnosis and treatment. And we're going to hopefully touch on many of those issues today. So why does this topic matter? Well, the comorbidity, meaning the simultaneous presence of both conditions, is surprising. Yep, I think sometimes clinicians often will miss the connection, and misdiagnosis will potentially lead to incomplete treatment or inefficient treatment. When both conditions are present, there might be a time when you treat the OCD first and then the eating disorder because the OCD is not allowing for the eating disorder to be addressed. There might also be times when you treat the eating disorder first because the consequences of the eating disorders are the ways in which the eating disorder might be impacting on the person are primary and therefore needs to be addressed first. But then there are also plenty of times when you have to treat both simultaneously because, for all intents and purposes, they're inextricably linked. And this can be extremely complicated, it can be extremely nuanced, and it can be terribly confusing. Certainly for the family members of the folks who are affected, for the folks who are affected themselves, not to mention the clinicians who are trying to provide care. So our goal today is to provide some insight into how to better identify these overlapping behaviors, how to better identify them earlier on, and guide people towards more effective and ultimately better integrated help. So for some additional context, I'm going to be approaching this topic from the vantage point really largely of eating disorders, which has been the primary area of focus, where comorbidity nevertheless is going to rely on the ways in which our understanding and experiences with both eating disorders and with OCD really inform one another. We're going to look at the phenomenologic overlap, that is, the ways in which the two entities overlap with one another, the OCD with eating disorders, and then discuss the resulting questions and challenges to treatment that arise from their comorbid presentation or simultaneous presentation. And again, as with any exploration of clinical entities that are sort of external to eating disorders per se, or external to OCD, this conversation will hopefully also tell us something about the core nature of eating disorders, as well as the core nature of OCD, and serve to further our understanding so that we might better help loved ones, help our clients who are suffering from these very serious and deadly illnesses. So we start with looking at eating disorders and obsessive compulsive disorder, two clinical entities that can be, I think, among the most challenging to treat in and of themselves, let alone when they occur together. Clinical entities that are among the most enigmatic and difficult to comprehend of psychiatric illnesses, and clinical entities that are particularly pervasive in their effects on the persons and families who are affected. So before we dive into their specific presentations, I'd actually like to start with looking at some of the interesting overarching parallels between eating disorders and obsessive compulsive disorder. Both are particularly salient illustrations of something that I think is a fundamental paradox of mental health care. One of the core challenges of mental health care in particular, I think a little bit in contrast to physical health care, for example, or medical health care, especially when the illness is grounded in something like anxiety and fear. One of the central challenges is that most of us, I would hope, go into this kind of work with the intention and the goal of trying to alleviate another person's suffering. If you're a loved one, you're approaching this, I think, hopefully with the idea that you don't want to see your loved one suffering and in pain. But in many ways, what we need to do in order to achieve that, and it can sort of run counter to that core mission, in that sometimes the best ways, or really oftentimes, the best way to alleviate someone's emotional pain and suffering, especially with something that's based in fear and anxiety, is to actually help them attend to it more intensely rather than less intensely. And that can be enormously difficult because in the short term, it can oftentimes amp up the distress that that person is experiencing. And this is particularly true when what brings someone into treatment are behaviors that come out of extreme efforts to avoid feeling the exact things that you're asking them to try to pay more attention to, that cause a lot of internal turmoil and distress and additional fear and anxiety. So in particularly in inpatient or residential treatment settings, which is what I've spent most of my career doing, this is the vast majority of the folks that we tend to see. And this truism is particularly relevant in the case of this overlap that we're talking about today, where something like exposure and response prevention, which we'll discuss later, which has long been the treatment of choice for OCD, and which is also something that is used widely and very successfully for eating disorder treatment, is predicated on the idea that direct exposure and experiencing of exactly those things that a person fears most and therefore avoids the most really essential to reducing and eliminating that fear in the long term. So it's really this contrast between what might happen in the short term, which is increasing distress, and what we're hoping happens in the long term, which is decreasing anxiety and fear in the long term. And additionally, both of these clinical entities have, as part of their history and development, this particularly enigmatic quality. From the earliest descriptions of eating disorders in the 1600s to the 1800s, where the term anorexia nervosa first gets coined, there's this paradox of eating disorders as an apparently physical ailment without any clear physical signs. And the resulting consequences of things like malnourishment that are clearly physical, malnourishment coming not having a clear physical cause or etiology. And that's not only true, something that was true back then, but something that still remains true about the illness. OCD, or as it was initially termed, obsessive compulsive neurosis, was originally described as a form of monomania or partial insanity. It was termed partial because although the affected presents with thoughts that they report that they couldn't control, as well as then the accompanying ritualistic and repetitive behaviors, because insight and intellect, for example, are largely preserved, these things were clearly not the result of something like psychosis or delusions. In other words, there was this paradox of an apparent sort of quote unquote neurotic ailment that didn't have a clear neurologic cause or a clear sort of neurotic cause in the parlance of the time. Um, and so this sort of historical coincidence of the ways that both of these illnesses came to be described, I think, reflects some of the overlap that we're going to be focused on today. There's sort of been a longstanding interest in the possible relationship between obsessive compulsive disorder and eating disorders, particularly anorexia nervosa. This has long been both theorized and talked about in the literature. Among the first reports in the 1930s, Palmer and Jones provided 4 case studies of anorexia as demonstrating the basic personality being in common with compulsion neurosis. Waller, Kaufman, and Deutsch reached a similar conclusion in the 1940s for 2 patients with anorexia nervosa, and suggesting that their personality structure followed the lines recognized as compulsive and obsessive. And so, due in part to these personality-based clinical similarities, clinicians have argued at various points for renaming eating disorders or anorexia in particular as a compulsion neurosis. And although those naming changes were not ultimately adopted, the suggestion itself reflects the view of many in the field that eating disorders, anorexia in particular, was very closely related to OCD, perhaps even a variant of it. Um, I think I'm certainly in a camp in a camp that would say that eating disorders ought to be in the broader category of anxiety disorders, along with OCD. So sort of existing alongside of OCD in the same overall category. And I think there are a lot of good reasons for that. There are also good reasons to keep eating disorders sort of separate, because there are a number of features of eating disorders that make it unique amongst other anxiety disorders. But sort of conceptually, from what we're understanding from the genetic research, from what we're understanding from the neurobiology as it begins to unfold, it makes a lot of sense to conceptualize at least eating disorders as being in the same category of anxiety disorders as OCD exists in. But even before this recent advent of genetic linkages and clues to a shared biologic etiology, the developmental course of the illnesses have a lot in common. And as we'll go on to talk about today, there's a lot in common in terms of their manifestation and the ways in which we see the core features being shared between those two illnesses. So it's little wonder that OCD has been among the most extensively studied anxiety disorders and really most extensively studied comorbid conditions in eating disorder samples. So before we look at the overlap, let's establish some of the fundamentals. So I keep using the term, but OCD, or obsessive compulsive disorder, is defined by two core components: obsessions and compulsions. Obsessions are not just common worries, they're intense, intrusive thoughts, images, or urges that cause significant amount of distress. And then compulsions are the attempts to neutralize that anxiety. They're behavioral or mental rituals that are performed in a repetitive, in a repetitive compulsive manner to reduce the anxiety caused by the obsession. And we'll get into that more in a few minutes as well. More broadly, obsessive compulsive disorder is a neuropsychiatric disorder that involves distressing, intrusive thoughts and then related compulsive behaviors, as I said. Considerable evidence has indicated that there are certain sets of neurocognitive impairments that we see in people struggling with OCD that are distinct from other anxiety disorders that I think are important to understand, that give us an insight into why we see some of the behaviors that we see, as well as why treatment can be so difficult for OCD. In the cognitive domain, one of the more consistently reported deficits is in visual spatial memory and organizational skill, especially for complex visual stimuli. So as an example, it's things like remembering where an item was placed in a room. So just being able to visualize where you might have left your keys in a room, for example. Mentally rotating an image is a visual spatial skill. Task prioritization would be a more organizational skill, that is figuring out what task one needs to do first if there's a bunch of tasks that need to happen in sequence, as well as things like breaking down a project into manageable steps. There are other cognitive functions that are frequently looked at with regards to OCD, which include a number of different, what we would call executive functions. Executive functions refer to a set of higher order metacognitive abilities that help you do things like planning, help you with organization, regulating your own behavior, things like managing time and achieving goals. So there are a number of psychiatric conditions, ADHD, obviously, given the set of skills I just talked about. Certainly, eating disorders, as well as other psychiatric conditions that involve executive functioning, but OCD is also one of them. These skills act like the brain's sort of management system or organizational system. They allow you to do things like think before acting, stay focused, control our impulses, and then in some ways, most importantly, adapt when situations change. It's all of these things that go into planning and organization, holding something in working memory, that is holding something in your short-term memory so that you can kind of manipulate that thing that you're holding and come up with another answer, like in doing arithmetic in your head, for example. It's also involved in inhibitory control that allows you to pause and think before acting. Cognitive flexibility, as I mentioned, that allows you to do things like set shifting, that is changing your response set from one set of rules or expectations to a different one. That helps in adjusting plans and switching strategies when a given strategy is not working, engaging in self-monitoring, emotion regulation, things like that. So individuals with OCD have been observed to experience difficulties in a number of areas, including the ones that I just mentioned. Difficulties in inhibiting ongoing cognitive and motor responses, right? You can see that just in the key symptoms of obsessive compulsive disorder. The compulsions are repetitive behaviors that are largely not under the person's conscious control. That happen as a result of the obsession, or the result of the distress that happens from the obsession. Set shifting, shifting your attention from one aspect of a stimulus to another, engaging in higher level decision making, generating, recalling verbal information as well as the visual spatial information that I mentioned earlier. So you can see all of this in the main features of obsessive compulsive disorder. That's the occurrence of persistent, intrusive, and time-consuming obsessions and compulsions. Obsessions are often inappropriate and intrusive thoughts, impulses or images, such as concern over contamination, which is a very common one, symmetry, order, things like that. Compulsions then are the repetitive behaviors, whether they're overt or covert, whose goal is to prevent or reduce that anxiety or that distress. Moving on to eating disorders. Eating disorders are similarly serious mental health conditions that are characterized also by obsessive and distressing thoughts, emotions, and behaviors, which tend to be related more to food, eating, body weight and shape, and other similar concerns. These disorders, important to note, are not just about food, even though many of the behaviors involve food and weight and body, but they often will reflect deeper struggles with things like control, self-worth, anxiety, or emotion regulation. People with eating disorders may often use things like food intake or controlling their food intake or focus on their body image as a way of coping with difficult feelings, overwhelming feelings, trying to gain a sense of control over something they perceive to be out of control, or just managing distress and stress. However, those resulting behaviors, much like in OCD, can be physically dangerous in the case of many of the behaviors of eating disorders, as well as to be psychologically distressing. They can affect your health, your relationships, as well as significantly impact on your daily functioning. The most common types of eating disorders that we talk about are anorexia nervosa, which involves restriction with intense fear of gaining weight, distorted body image, severe restriction of food intake, often leading to dangerously low body weight. It's often associated with personality traits like perfectionism and a strong need for control. There's also bulimia nervosa, which involves repeated cycles of binge eating, again, largely feeling associated with a feeling of being out of control, followed by compensatory behaviors like self-induced vomiting, excessive exercise, or restriction, as well as abusing things like laxatives or other kinds of substances. The most common eating disorder is binge eating disorder, which involves recurrent episodes of eating large quantities of food quickly and to the point of discomfort, so binges, often accompanied by things like guilt or shame, but without other kinds of compensatory behaviors that would put it more into the category of bulimia nervosa. There's also avoidant restrictive food intake disorder, or RFID, which is somebody who has difficulties and manifests in limiting food intake due to things like sensory sensitivities, other things like fear of choking or vomiting, or a lack of interest in eating that are not necessarily driven by body image concerns, so as to distinguish it from something more like anorexia or bulimia. And then there are other specified feeding or eating disorders, OSFED. These are clinically significant eating disturbances that don't fit neatly into the other kinds of categories, but still cause a significant amount of distress or impairment. There are some common psychological and emotional features that go across eating disorders. There's can be a significant preoccupation with food, with calories, or with body weight, a significant amount of perfectionism and rigidity in thinking, an intense fear of losing control, significant amount of shame, guilt, or anxiety, especially around eating behaviors, difficulty recognizing hunger or fullness cues, as well as other somatic cues, emotional numbness or avoidance. These are all very common psychological and emotional features that are common to many of the eating disorders. One of the reasons why this matters so much is that eating disorders go on to affect every system of the body. They're among the most life-threatening of mental health conditions. They have among the highest mortality rates of any psychiatric condition, largely because of the very immediate impacts on our health due to restriction, but also due to many of the compensatory behaviors that we see. Self-induced vomiting, even excessive exercise can have very significant impacts on your physical health. But we also know that with early intervention, early therapy, and supportive care, that full recovery is certainly possible, even often through a combination of medical, nutritional, and psychological treatments. Eating disorders, as I said, are characterized by drive for perfectionism, a high degree of obsessive compulsiveness, high levels of neuroticism, negative emotionality, harm and pain avoidance, and really generally avoidant personality traits, low levels of self-directedness. So these are also, you might notice, many of the similar personality traits that are also present in obsessive compulsive disorder. And I want to finish off with eating disorders just by saying that importantly, we also understand what eating disorders are not. Organizations like the National Eating Disorders Association, as well as many other organizations in the eating disorder field, have spent a lot of time really trying to disseminate this very important piece of advocacy and information, which is that eating disorders, largely in contrast to sort of popular understanding or popular portrayals in things like the media, eating disorders are not disorders of vanity. They're not disorders about wanting to look better. And I think oftentimes they get dismissed as that. They actually stem from a profound sense of, I'm not good enough, I'm defective, I'm broken in some way, I'm not as good as other people. That's really what's at the core of this illness. It's really wanting to be better, and because it's coming from that profound sense of not being as good. And it's not simply about wanting to look better. That just happens to be one of the ways in which eating disorders get manifested. But I think it belies the seriousness of this illness to write it off as something like vanity or something like lack of willpower. And that's one of the things that we've been clearest in coming to understand about this illness. All right. One place to start starting to look at the overlap is in trying to understand the function of the compensatory behaviors that are present in both illnesses. The form of the behavior might look similar, but the function is also very similar, which is anxiety reduction. In OCD, the function of the compulsion, the ritual, is to reduce anxiety. Compulsions, the repetitive behaviors and rituals that one finds in OCD, serve to reduce anxiety and distress that come up from the presence of the obsessive thoughts and the underlying fear that goes along with those obsessive thoughts. Similarly, in an eating disorder, the food, the weight, body, or body-related rituals that are present, and then the compensatory behaviors that happen serve the function of avoidance or distraction. The behaviors are all really serving that some similar function, and that includes restriction. Food restriction has that same underlying purpose. It's a compulsive behavior that's aimed at controlling anxiety that might be related to, specifically in this case, food, weight, or body shape. All of these are anxiety-driven compulsive cycles, and so to understand to understand the cyclical nature of these behaviors is terribly important in starting to understand these illnesses. You have, for whatever reason, the presence of that anxiety that's driving both. The person starts to engage in any number of different kinds of avoidance behaviors. In eating disorders, it might look like the food-related behaviors. In OCD, it's going to be in the category of the compulsions. The problem is that provides some significant short-term relief. If you imagine somebody who's really struggling with these uncontrollable distress that comes from fear and anxiety and intrusive thoughts, and then you find a behavior, even if it might not be even if it might not be a particularly adaptive behavior, but you find a behavior that, at least in the short term, takes away that anxiety and that distress. Of course, you're going to be motivated to continue to engage in that behavior more. The problem is that the price one pays for that short-term relief is longer-term anxiety and longer-term and longer-term increase in the amount of anxiety that's produced. And I'll show you a different way to look at that cycle in a couple of slides. Well, actually, in this slide. Again, when we look at both eating disorder and OCD, you can also think about it in this way. You have somebody who is predisposed to extreme sensitivity, and it can be a genetic predisposition. It can be through any number of epigenetic factors. But just for whatever reason, someone is predisposed to be relatively more sensitive. Anybody who's relatively more sensitive is going to have an impairment in their ability to modulate their own emotional response. That is, that it's going to be more difficult to modulate your own emotional response because of that degree of sensitivity. If you have more difficulty modulating your emotional response, you're going to tend to experience emotions as subjectively much more aversive and overwhelming, even positive emotions. Our natural instinct when we experience anything aversive, whether it's I'm touching something hot, or in this case, something that might be more emotional or psychological in nature, is to attempt to not feel that thing anymore. If I'm touching something that's burning my hand, I'm going to move my hand away. If I'm feeling something more emotional or psychological that's distressing, I'm going to do whatever I can to not feel that anymore. That's a perfectly sensible survival mechanism. And in fact, that's just simply how we're wired to be. The problem is that, as I said, the more frequently one attempts to engage in strategies that rely on suppression, avoidance, denial, any of those kinds of control mechanisms, you're going to begin to then over rely on strategies like worry, obsession, compulsive behaviors, or at the extremes, self-harm behaviors, which only serve to make you more sensitive. The more sensitive you become, the even more of an impairment you have in your ability to modulate your emotional response. The more things start to feel aversive and overwhelming to you, the greater the drive to engage in these behaviors. That is very much the anxiety rooted experience and cycle of both eating disorders and OCD. So this is then the pathology map that we can start to see. We can see certainly how that cycle works in OCD. You have an obsessive thought that produces distress that then drives engaging in compulsions, which provides temporary relief, but then in the long term, that just increases the strength of the obsessions and the distress that comes about. So that's the classic OCD cycle. And it works the same in eating disorders. You have in both conditions, the behavior is maintained by the anxiety reduction cycle that you see here. The compulsive act provides a temporary, powerful burst of relief, but that relief is a trap. So it might be the obsession might be this food is dangerous, or it's gonna make me fat. The anxiety is then produced, which induces an intense sense of panic or fear. That drives the compulsions, the compensatory behaviors, restriction, binging behavior, purging behavior, or other compensatory behaviors. That in turn provides temporary relief, so your anxiety drops, but then it strengthens that preoccupation and connection that you've developed between I must therefore engage in this behavior if I want to get any kind of anxiety relief. So the behaviors only start to escalate because that's the nature of this kind of cycle. It teaches the brain that the only way to feel safe is to perform the ritual or to engage in the compensatory behavior, making the compulsion even stronger and the next obsession even more intense. And part of what's happening is most therapists will show clients some version of this kind of graph. But what's happening is that, as you can see in the graph in the green part, that for that person, for whatever the reason might be, whatever is driving the obsession or the eating disorder thoughts, that person is experiencing the increased slope of that green part of the line. Their anxiety is starting to rise over time. If you look at where the arrow is pointing, where it says facing the anxiety, what's happening when you engage in either the compulsion or when you engage in the eating disorder behavior is that you're engaging in that behavior, which sort of interrupts the natural course of anxiety. So all you've therefore experienced is anxiety just goes up and up and up and up. And so to you, how it feels is that if I don't do this thing, if I don't do these behaviors, my anxiety is only going to keep going up. And at some point, I'm just going to lose my mind, right? Because that's all that person's ever experienced. And in fact, what they need to experience is the natural course of anxiety, even if you do nothing about it, is that anxiety rises. Anxiety then at some point has to plateau just because that's how we're wired. Our nerves can only fire at that rapid rate for so long. So at some point, the nerves fire slower and slower, which is sort of that plateau. And then again, at the other end of it, just at some period of time, after some period of time, anxiety naturally comes down even without you doing anything about it. So for example, the purpose of the kinds of treatments that we use, largely exposure and response prevention, is to help somebody experience that cycle of anxiety goes up, anxiety plateaus, anxiety comes down, without engaging in their behaviors. Because it's really only by experiencing that natural course of anxiety reduction that any of us would actually believe that you don't have to engage in the behavior. But that's where so many people get stuck in this kind of cycle. So let's look at some other places where we can see this kind of overlap. There's obviously overlap in obsessional thinking. There are core obsessions where we start to see the first major sort of commonality between OCD and eating disorders. In both conditions, thoughts become intrusive, thoughts become extremely rigid and overwhelming, very difficult to challenge or to change. For someone with OCD, they might obsess over things like contamination or symmetry or order. And for someone with an eating disorder, their obsessions might be over calories or food quality or purity to an excessive degree, like a fear of dirty food that goes far beyond just sort of health consciousness. In OCD, there might be an overwhelming need for things like symmetry, order, or exactness. In an eating disorder, it might be order or symmetry in how food is placed on a plate, the order in which the food is eaten, or it's things like food not touching. In OCD, it might be an obsession about health. In an eating disorder, it might be about health, specifically with regards to weight, as well as about things like purity. So you can sort of see the analogous obsessional thinking patterns that exist in both eating disorders and OCD. We can similarly see this kind of overlap in looking at compulsive behaviors. So the obsessions drive the compulsive behaviors. And in classic eating disorder behaviors, like cutting food into tiny pieces, weighing out portions very precisely, eating alone in order to hide rituals, these are all clearly sort of compulsive acts that are driven in nature. They're performed to reduce the anxiety of the obsession. Um, their purpose is to reduce the anxiety of the obsession. So in OCD, it might look like lining objects up, arranging things for symmetry or evenness, or doing other things in order to produce this kind of internal just right feeling that so many folks with OCD will describe. In an eating disorder, it might look more like food rituals, cutting food into exact size pieces, eating in a specific order, using only certain utensils. In OCD, safety checking might look like checking doors and windows repeatedly, checking to make sure you turned off your iron repeatedly. Or it might be harm related, checking to see that you didn't run someone over while driving, which is an extremely distressing form of OCD. Or mistake related, where you are rereading or rewriting something just to make sure you didn't make a mistake in it. In an eating disorder, it might look something like repetitive checking or scanning of the body for perceived flaws, checking labels for ingredients or calories to make sure that you're not going to get something you don't want. In OCD, it might look like something. Avoidance might look like avoidance of public bathrooms, avoidance of touching doorknobs, avoidance of physical contact, and avoidance of any number of other situations that might trigger an obsession. In an eating disorder, avoidance might look like refusing to eat outside of the home because you can't control it as much, refusing to eat in social situations, avoiding certain food groups, and not for reasons of having an allergy, but for reasons of fear or anxiety. It's also important to note that the strength of this overlap really varies. In the context of anorexia nervosa, which shows the most significant comorbidity with OCD, at its core, it's often things like rigid control and perfectionism, which are the hallmarks of both conditions. RFID is also highly connected, often involving strong sensory related aversions or a fear of adverse consequences, which can sometimes look very much like OCD kinds of behaviors. And then in binge eating disorder or bulimia nervosa, the binging and purging behaviors are often highly ritualized and compulsive in nature as well. I've mentioned perfectionism and rigidity a number of times, and it's an important element of commonality in terms of personality traits. Both conditions thrive in an environment where small mistakes can be seen as catastrophic or deadly in some other way. And this deep need for order and control often fuels the rigidity of both eating disorder rules as well as insistence in the context of OCD. Anything outside of that rule tends to create an intense amount of anxiety and distress. All of that leads to things like high levels of self-criticism, fear of failure, as well as things like rigid thinking and difficulty coping with uncertainty or deviation from rules. And that's one of the reasons why treatment is so challenging for both conditions. And then briefly, we can't discuss the eating disorder OCD overlap without mentioning body dysmorphic disorder. So it's not a particular it's not a particular focus of this presentation, but I think it's important that we mention it. Body dysmorphic disorder is related but distinct. It involves a preoccupation with a perceived flaw in a part of one's body. It results in intense surveillance for any perceived flaws, scrutiny of the body in particular, and then compulsive checking and hiding behaviors. So you can start to see just even in that description a little bit of overlap with both OCD and eating disorders, but body dysmorphic disorder really is its own thing. The body focus in body dysmorphic disorder is really about a perceived physical defect, whereas, for example, the body focus in eating disorders revolves much more around things like shape or size. The preoccupations with weight and shape and eating disorders as a strong dysmorphic component. That is, there's a certain degree of body dysmorphia that exists, which might link it to BDD. But as I said, they're quite distinct in their presentations. Um, we when the more we've looked into some of the neurobiology of body dysmorphic disorder in particular, then we start to see the differences even more. Body dysmorphic disorder appears to involve the visual cortex and the parts of our brain responsible for vision, as well as for focus on details as opposed to the gestalt, even though those things are present in eating disorders and to some extent in OCD, the same parts of the brain are different parts of the brain appear to be involved in eating disorders and OCD than in body dysmorphic disorder. How common are these conditions? Well, in the United States, about 2.3% of people will have OCD in their lifetime. That's about 1 in 40 adults. And about 9% of the US population will have an eating disorder in their lifetime. And the data about comorbidity is actually quite compelling. In a recent review of global comorbidity data, studies show that about 15% of people with an eating disorder also have comorbid obsessive compulsive disorder concurrently, that is at the same time. And about 18% of people with an eating disorder have had OCD at some point in their lives. Earlier data has actually indicated that the overlap might be as high as 41% of people with an eating disorder who at some point who at some point also experienced OCD. And about 17% of people with OCD also have experienced eating disorders. Now, if we compare that to the relative prevalence in the general population, you can see that this overlap is significantly higher than it is the general population. The lifetime prevalence of OCD is significantly higher in eating disorder and vice versa. And we're starting to see genetic and neurobiologic factors that are being actively investigated as producing many shared causes of this to the extent that we can know it at this point. What are some warning signs that are specific to this combined presentation? Well, a number of the warning signs involved in one can certainly be applied to the other in terms of red flags to look out for. So let's translate some of that into action. What do these overlapping behaviors then actually look like? You can look for certain behavioral red flags. The amount of time engaged in a compulsion. If the compulsions take up more than 1 hour a day, especially if it's happening every day, that's something certainly to be concerned about. If there's a significant amount of distress, if the person is visibly upset or anxious, if a ritual is prevented, that's something that would make something more concerning than if they just find it like annoying. If there's a significant amount of impairment, we would always be concerned. If engaging in these behaviors interferes with one's social life, with school, one's ability to function at work, these would all be indications that something is more concerning. We want to watch for any rituals that consume time and attention in this way. If someone's spending an excessive amount of time engaging in eating disorder behaviors or other compulsions, and then become significantly distressed if certain things happen, then that's something that we would think that there's a powerful anxiety-driven compulsion at play. In terms of food or eating rituals, it might look like extreme slowness in eating, as well as things like ritualistic behaviors like cutting food very small, making sure food isn't touching, separating the food, eating food in a certain order, having rigid rules about things like the order in which the food is eaten. Eating only at very specific times or in very specific places can also be a part of this pattern. Also, things like excessive washing or cleaning of food or utensils, or an inability to eat foods that touch can often be a specific way in which the overlap of OCD and eating disorders can manifest. And then obviously compulsions can extend beyond just food related behaviors. Compulsive exercise is a significant red flag. That's not, and it's important to note that this isn't just about fitness or health. It becomes a non-negotiable obligation or compulsion. Similarly, excessive and distressed checking of one's body in the mirror or on the scale is a classic kind of compulsive act aimed at reducing anxiety that comes from thinking about having a perceived flaw or some other element of body surveillance. So you might see someone engaging in compulsive, non-enjoyable exercise, even when they're injured or sick. They might engage in repeated measuring or weighing of their body or staring at themselves in the mirror for flaws, refusing to wear certain clothes, whether it's based on color, texture, or fit, that becomes extremely rigid. These are all many of the ways in which some of this overlap might be manifesting. Then there are also psychological indicators, someone who shows a lot of extreme black and white thinking, that is, foods are either good or bad, and nothing exists in between. If there's a significant amount of intolerance of uncertainty, certainly if there's a lot of guilt and shame associated with the behaviors, that's something always to be concerned about. And then finally, in many ways, most concerningly, if they're engaging in these behaviors in isolation, that is, they're pulling away from not only social events, but pulling away from loved ones and family members in order to engage better, to more easily engage in these kinds of compulsions, that would be a place of extreme concern. And this is really one of the core reasons for this kind of presentation. If a clinician only sees the food restriction but misses the other OCD anxiety that's driving it, treatment is going to be incomplete. Simply restoring weight isn't going to do anything to remove the compulsions that might be driving other OCD behaviors outside of eating specific behaviors. So we have to treat the anxiety and the rigidity to truly address the eating disorder, whatever might be underlying it. If a treatment fails to address one part of this overlap versus the other, what it will lead to is either incomplete treatment or extremely high rates of relapse in the end. I think this question often comes up of when should we seek help? I think seeking help when the behaviors are causing significant distress or significant functional impairment in a person is certainly one place to start to think about it. I certainly don't think one ought to wait for a weight that's low enough or for a level of compulsion that's serious enough, whatever that might mean. I think it's usually pretty clear when it's causing impairment in a meaningful way, or certainly when it's causing significant amount of distress for somebody. Um, as soon as that starts to become, if you're the loved one or if you're the clinician seeing that, that would be an immediate place to at least get a consultation. And just to finish off with some sort of actionable steps, I think starting that difficult conversation, if you start to have concerns about it, can be extremely difficult, but it's also terribly important. And if you're having that conversation, you might think about things like focusing on the anxiety or the other feelings that are coming up, as opposed to the food specific behaviors or the ritual specific behaviors. I've noticed that you seemed really stressed or really worried. I'm worried about what might be happening with you, as opposed to focusing on specific behaviors. Using I statements, I feel worried, as opposed to, you're doing X, Y, or Z. Avoid blaming language or giving unsolicited advice, and really stay at that level of focusing on that person's emotional distress and anxiety. Finding ways to validate the struggle as opposed to the behavior, acknowledging the eternal pain that person must be going through. I know this feels completely out of your control right now. You seem to be having so much difficulty. That must be terrifying for you. Um, Finding ways to reframe what might be happening. Rigidity as the symptom as opposed to the solution. The compulsion as a misdirected attempt to try to cope with the fear that you eventually pay a longer term price for. And then finally, thinking about the right professionals who might be able to help. Again, we're talking about two clinical entities that really, both of which really require a fair amount of specialization. Um, so if there's eating disorder symptoms that are present, I think it would really be important to consult an eating disorder specialist, whether it's a therapist, dietitian, or an eating disorder team, to address the food, weight, and body components. Similarly, again, if it's outside of your own area of expertise, to find an OCD specialist who can engage in exposure and response prevention, which is a modality that requires training and practice. And then finally, if it's relevant, a medical doctor or a psychiatrist, both for psychiatric medications and pharmacologic treatment, but also, especially with something like an eating disorder, having a medical doctor to really monitor the physical impacts of not only the eating disorder behaviors, but oftentimes there are potential impacts from the treatment and making changes in the person that might not be evident without a medical professional following. Um, to give us a few minutes for questions, I think to recognize the function of compulsions in the overlap, to look for things like rigidity that really signify that there's compulsion behind what might be happening with somebody. And then to really think about integrative care, how we ensure that treatment includes both elements of when we're seeing this overlap, both includes both treatments for the eating disorder as well as for the OCD. And then, both of the organizations that are sponsoring this presentation have tremendous resources that people can access, and any of you can also feel free to reach out and contact me directly with any questions. And with that, I think Molly, were there questions that people had in the
Yes,
chat?
we have a lot of questions today. I'm not sure if we'll get to all of them, but we'll try our best. First up, if eating disorders stem from a deep sense of self-inferiority or defectiveness, is this also true of OCD? And if not, would that be a major difference
No.
between them?
Yeah, that's a
And how
great
would this
question.
affect clinical approach?
Yeah, that's a great question. It's it's not as cardinal a symptom in OCD as it is in eating disorders. I mean, I don't think to put it more bluntly, I don't think eating disorders exist without that core sort of self-esteem, self-loathing element in place somewhere. It's not necessarily a cardinal feature of obsessive compulsive disorder unless it happens to be an element of that particular person's obsession. So yes, that would be one place where there is some difference. I I talk about it more in the context of being a core element of eating disorders, um, to really understand what eating disorders are.
Thank you. I think this sort of ties in. Do we know of any research into the way cultural environment, messaging, and values affect eating disorders versus OCD?
Um, I can answer. I can answer it a little bit more on the eating disorder side. Um, So it's a complicated answer actually. So we know that eating disorders are have multiple sort of causative pathways. Um, so at, at the biggest picture, is it something that is sort of culturally determined? I mean, probably not really. And you can sort of see it in a number of ways. We know that eating disorders have existed from before there was anything like social media, before there was there were even magazines or mass media of any kind, and the absolute sort of inundation of social media that we exist in now, like that's very much all of our world now, that hasn't necessarily resulted in a significant increase in rates of eating disorders, even though you can see other people's bodies, for example, much more readily now than ever before, but we're not seeing a massive increase in eating disorders. Um, and so I think to the extent that represents sort of cultural values, I think we are pretty clear that that kind of cultural value doesn't impact on eating disorders. You really have to be predisposed in one way or another, whether through events that happen to you or through some sort of genetic predisposition or other epigenetic factors that might happen afterwards. Um, you have to have probably some sort of risk factor to develop the illness, because we're all exposed to those messages, and we don't, as I said, we don't see a significant increase in rates of eating disorders. Now the caveat to that is that if you are predisposed, the more access you have to those kinds of cultural messages, then the more impacted you're likely going to be. So for example, it used to be, again, before social media, it used to be things like people who were engaged in sports, or things like ballet, or certain other activities where there's a real body focus. Those folks tended to be at a slightly higher risk for developing an eating disorder. But it's also true that if you have this kind of perfectionistic personality, you are likely to be more drawn to something like competitive athletics, or modeling, or ballet, or something like that. So it's a little bit of a chicken and the egg, chicken or the egg thing. Um, But to that extent, there's certainly some effect of kind of cultural messaging at that level, but it's not something that sort of operates at a bigger kind of more, I don't know, population level, if that makes sense.
I think
And I
we can.
think
Okay.
largely true for OCD as well.
Okay. I think we can squeeze in one quick question before we wrap up, Molly.
Okay, well, I just want to we have a lot of questions for loved ones and sort of general tips for kids, teens about getting them into treatment or how to work out, how to treat both conditions.
Yeah, I unfortunately I think that takes a little bit of legwork and advocacy. I mean, if you're already engaged with a therapist or other professional who might be able to navigate some of this figuring out, that would certainly be beneficial. But if not, like I said, I think if you suspect that both are happening, to find people who really have an expertise. There are certainly people who have expertise in both. But if you can find someone with an expertise in one, they can likely also help find someone with an expertise in the other. Um, it's not hard to find per se, but I think it's terribly important, and it might, like I said, it might just take a little bit of legwork and advocacy to do.
We have come to the end of our time, and I just want to say thank you so much, Dr. Kim, for your time and expertise. We are so grateful to the National Eating Disorders Association for partnering with us on this very helpful webinar.